everyone, and welcome to the Sex and Wellness Podcast with Dr. Mary. Today, I am here with Dr. Stephanie Vertrees. She is a board-certified headache specialist and neurologist, and she's here to talk to us about headaches and how they can be treated in medicine and in lifestyle. So thank you for coming.
Thanks for having me.
Yeah. I'm excited. We've been kind of back and forth on chatting and getting you on here. So she has a clinic here in Austin, Texas. So we will link that in the podcast below. But we're going to go ahead and jump into headaches. So what are some of the common causes of headaches that you see in your clinic?
So most headache syndromes are related to a genetic disorder. And the genetics basically make the brain more sensitive than the general population in terms of its sort of susceptibility to environmental triggers.
Mm-hmm.
So meaning your brain is going to be more sensitive than the normal person to things like lack of sleep, stressors, musculoskeletal issues in the neck and shoulders. And those things generally are things that can build up. It's usually not one thing that triggers a person. It's the additive effect of things that pushes them over the edge, and then they will trigger a headache. They'll go over their threshold and they'll trigger a headache. And that can happen in the setting of migraine. It can happen in the setting of tension type headache. It's not just exclusively one headache syndrome that does that.
So what you're saying is, genetics are a part of it.
Mm-hmm.
Do you feel like if somebody maybe has a history of PTSD or trauma, that could tie in with genetics, or would it be, nature versus nurture type stuff? What do you typically see with that?
So I think there's a component of both things going on. So, for example, the genetic side of it would be that you have a susceptibility to migraine headaches or tension type headaches or cluster headaches. But the nurture side of it would be that PTSD is acting as the trigger, or stress is acting as the trigger, or lack of sleep is acting as the trigger. And generally, it's not just one thing that triggers a person. It's usually the additive effect of these triggers that then pushes a person over their threshold, and then they will get their headaches as a result. So you can have that genetic predisposition and not necessarily have headaches. So as long as you're working on your trigger burden, so to speak, it doesn't necessarily have to push you over that threshold. So lifestyle is actually really, really important in terms of managing headaches.
Yeah, I think that's so important because a lot of times people in general, especially if you're dealing with chronic headaches, want a quick fix, right? Because the pain can be unbearable and debilitating. But that piece, the lifestyle piece is massive. And I don't think that's talked about much at all, except obviously with you, right? But that's why you're here, because I want to talk to you about it. But incorporating medicine with lifestyle, right? Because they're all intertwined. We can't look at somebody just as somebody with just a headache, right? What are their lifestyle and the things that you're talking about?
I think a lot of times people view headaches as a symptom and not as a syndrome. And the reality is that it's really a syndrome. It's really a condition. And you have these things that influence, that condition. And, a lot of times, when you're viewing it more as a symptom, oh, well, let's just go pick up that Tylenol or that Advil or whatever, and let's pop a pill and let's just knock it out and we're done with it. And that might work a few times, but left unchecked, over time, that can get worse and worse. And then that's often when people come to see someone like me, is that they've been kind of managing it on their own, but not really managing it. And then it all builds up and then they have this out of control headache syndrome.
Yeah, the compounding effect over and over and over.
Correct.
I think a lot of that comes too just from our society and just teaching us how to not be in check with our body.
Yes.
For sure. I've seen a lot of people just kind of be passed through the system because almost it's just oh, we don't necessarily have the time to sit down and talk with somebody about lifestyle. It's just easier to kind of give medicine and move forward.
Right. I think, unfortunately, a lot of even our primary care doctors will do that. Again, they're, patients are complaining of headaches. It's getting treated like a symptom. they're not necessarily getting a diagnosis of migraine or a diagnosis of cluster or a diagnosis of tension type. The doctor may not even know how to make those diagnoses. And so then again, it's treated as a symptom, it's undertreated. And then because it's undertreated, it just over time gets worse and worse.
Yeah. And then it just like affects people's lives and can be pretty debilitating. And, we'll jump into this later, but I see a strong correlation with pelvic floor symptoms, jaw pain, and headache.
Yes.
And I think that whenever I bring that up to patients, a lot of people's minds are blown because they're just like, wait, what? I'm like, yeah, the beginning and end of digestion, right? And how that like affects how the jaw can affect your headaches as well. I think people think just sometimes it's either just the head, but not as understanding that, hey, it could be coming from the neck too, and the jaw, and, internally as well.
Right.
Just the combination of all of it.
Right. I think over time, as my practice has evolved and meeting you a few years ago and having our conversations, I've learned a lot about that. And I've come to appreciate, not only pelvic floor as being an issue, but even other things. I mean, I think it may not be a coincidence that women have a stronger predisposition towards migraine, and particularly women in their 40s seem to have a lot of trouble. These are women who have often had children already, pelvic floor dysfunction, and then everything is connected, and so then it's just downstream consequences, physically, with the pelvic floor leading to, core instability, leading to neck and shoulder instability, leading to headaches. I think we don't appreciate that. And I've even had, aside from pelvic floor, patients tell me, I had an ankle injury a few years ago, and then they've developed headaches after that. So I think we take for granted how our bodies are connected, the various parts of our bodies are connected, and things downstream really can make an impact. And we're compensating, like that ankle injury might mean that you favor your other leg, which leads to, your hips being misaligned, which means then everything above becomes misaligned. And the same thing can happen with pelvic floor instability. I'm certain of that now. We need to make sure it's strong and well balanced in order to make sure everything else is too.
Yeah, I think the ankle thing is spot on. I mean, every time I've seen somebody, like maybe they come in post-op and they're in a boot, or they tore something and they're in a boot. It's like the opposite side. So if it's their right foot, I see chronic pain in the left low back and then the right shoulder. It kind of like bounces. And we're not understanding that, hey, if we don't look at all of this and I just treat this ankle and then, you're just treating the neck and then somebody's just treating that other, it's like, well, what are we looking at as like a whole? Because it's those imbalances over time. And then that compounds to overwhelming the nervous system.
Right.
Right. And so then, and where is the base of our nervous system? In our brain.
Right.
And then, and kind of understanding it from a level of that, because then people can start putting pieces together and learning about their bodies and thinking like, oh my gosh, like I had no idea all this stuff was interconnected. I mean, even in PT school and even being a PT for years, I didn't realize it to the degree that I have in just the past few years and just dealing with my own health stuff. And then really diving more into pelvic floor physical therapy, and just my mind has just been blown in just how lifestyle can even just be like, it's just day-to-day stuff. I think people think, well, I eat fine and I exercise.
Right.
That's, well, are you doing
That's a part of it.
It's a part of it. Are you sleeping? Are you doing things you don't like? Are you people pleasing?
Right.
Like you were saying, like a lot of women get it. And I don't think that's a coincidence either.
No.
Because we tend to be quieter. We tend to be more people pleasers, right? And we've kind of been conditioned to stay small.
Right.
And that's changing.
Fold in,
yes.
Flex forward. Mm-hmm. Don't show our breasts because
Heaven
we need
forbid.
to be modest, even though we probably need to be a little more in extension than in that flexion. Yeah.
Yeah.
Lots of layers.
So many. And, I could go on and on about that stuff. Arista and I actually talked about some of this in a previous podcast, just kind of like an overall understanding of like chronic conditions and in general, and how things that, even just years ago, I was like, why am I healthy? Like I eat right, I exercise, like great. And then looking back, it's like, well, if you're like having road rage or you're just like irritated at the little things, we're not looking at, well, what else is really going on deep down? Like, why is it that you're feeling on edge or whatever that may be? But that takes a lot of inner work too, and therapy or introspection and, all the things.
Well, yeah. And in migraine, we also sort of see this feedback loop, right? Where even migraine in and of itself causes mood issues. So a person may have migraine and not have an underlying anxiety disorder. Migraine actually might cause anxiety to happen. And when you treat migraine, it gets better. But it can be kind of a chicken or the egg situation too, or just a vicious cycle of feedback loop. Because pain and, that anxiety of when you're going to get the pain just leads to more pain, which leads to more anxiety. And then it's never ending until you really harness it and get it under control. So,
yeah. And sometimes it has to get to a point where people are almost like sit down to force to look at it.
Yes.
Because it's easier to kind of not have to dive into some of that stuff. If like, oh, I get a headache every now and again, whatever. But if it's like, I am debilitated, it's stopping me from traveling, I don't even want to do X, Y, Z, and it's drastically changing your life, that's when we have to look at it. Right. As much as those times are horrible and they're not fun, it's like, you learn a lot more, but at the same time, it's still not fun to kind of go through that whole process.
Right.
And yeah, the whole lifestyle, it's crazy how all of that can affect everything. Like even just thinking about, I've had patients with like chronic headaches and even like some of your patients as well. And just even like talking about like, hey, when you feel tense, like where do you feel like, what do you feel like happening? And they'll talk about something really tense. And I'm like, hey, look at your shoulders, and they're like, oh my God, I didn't realize I was doing that.
Or folding in.
Hunched over, like gripping your hands, like how hard
clenching your jaw.
Yeah. Like just even bringing awareness to it can be a game changer,
right.
But, I know you're talking about that with your patients. I guess it was more of like in general when I have people with like headaches and stuff, I'm like,
well, and sort of like a neuromuscular retraining too of like, okay, that body awareness so that you're not clenching it, almost a fake it till you make it type of thing to just avoid that feedback loop from happening with the brain.
Yeah. And I tell people, I'm like, if you're squeezing your butt, you're probably squeezing your jaw and you're probably hiking your shoulders. So some of that is even fascinating to just even observe,
Right.
And like when you're having... Especially I see even like with women in like stressful executive jobs, maybe in like male dominated industries or just like in really intense industries where productivity is like above all else, right? And there's a lot of internal pressures that can happen. And just even noticing when you're in meetings or you're in difficult conversations, what is your body doing? And how can you kind of reset that afterwards, because we're always going to have stress. It's more of like, how do we get out of that loop of stress and regulate some of that.
Yeah.
I feel like we could talk forever.
I know.
So let's so I think one of the things that a lot of people get confused on is headaches versus migraines. So would you be able to kind of break that down a bit so people can understand that a bit more?
So I'm a headache specialist, which means that I specialize in a variety of headache disorders. So headache is sort of like the umbrella term. And, migraine is one of the diagnoses that falls under that umbrella. So, migraine is a diagnosis that's part of, the headache field. So cluster headache, tension type headache, hemicrania continua, et cetera, et cetera. There's many, many, many different kinds of headache syndromes. If that answers your question.
It does. So can you touch on just maybe like the most common, a few, and just like a brief kind of explanation of cluster headache, tension headache, and migraines and how those may be different from each other?
Sure. So the most common headache syndrome is tension type headache. It is actually the second most common affliction on the planet. The third,
really?
Yes, according to the World Health Organization.
Wow. Okay. I didn't know that.
The third most common affliction on the planet is migraine, actually. So both tension type and migraine are really common and mostly underdiagnosed. In case you were wondering, number one is cavities. It's very common.
Oh, okay. Fun fact.
A fun fact. So very, very common syndromes, largely underdiagnosed, undertreated. Cluster headache is rarer and mostly predominantly male, 2-to-1 ratio, and different manifestations. So I don't know if you want me to get into what each of the types look like.
I think that would help people so they can kind of understand, because they may not have, if they're in Austin, they'll have access to you, or in Texas, but some people are like, I was looking at my stats. There's people in Germany and Europe and different parts of the world that listen to this too. And it's like, what are some things that they could look for just in general, just to kind of be aware?
Yeah.
So symptom-wise.
Right. So tension type headache basically involves muscular tension associated with headache. And that muscular tension could be around the head and neck and shoulders. Migraine is distinguished from tension type headache, even though tension can also be a component of migraine.
Yeah, I've seen that.
It's very common, actually. But the main distinguishing factors is that a migraine has to be associated with sensitivity to light, sensitivity to noise, or both, and or nausea and vomiting. So you have to have a component of those things going on in order for it to technically be a migraine.
What about auras? Does that matter?
So migraine can present with or without auras. And auras, most aura is visual, but there are other kinds of auras as well that often go underappreciated. So there are actually motor auras where a person can get weak on one side of the body. There are sensory auras where they can be numb or tingly on parts of the body. They can also have vertigo as an aura, so dizziness, spinning, shifting. They can have difficulty speaking as an aura.
I bet the first time they have that, they're probably like, am I having a stroke?
Yes, almost uniformly.
Gosh, that must be so scary for people. It is
very scary. And so I think people underappreciate how powerful migraine can be. It is.
You don't understand it until you have one.
Correct. It is not just a headache. It is truly a syndrome. It's a brain syndrome. It's not a pain disorder. It's a brain disorder. And it's very powerful because it causes a lot of different symptoms. Another thing that migraine research has shown over the past 10, 15, 20 years is the presence of a prodrome, which is the first sign that a migraine is occurring, and it can happen hours to even days before the onset of pain, which can be things as subtle as feeling fatigued or irritable or urinating frequently or feeling thirsty or hungry or cravings, things like that. People used to think, for example, of chocolate as being a trigger for migraines. Now we're wondering if it's actually a craving and that you already have triggered the migraine, that you're actually already in it. And then it's really good information, it turns out, because the sooner you treat a migraine, the easier it is to get ahead of it. So if you can start to appreciate some of these non-headache signs of migraine as being your warning sign and acting on that, it actually really, really helps people.
So tension too can also include jaw too.
Right.
Can you explain where on the face and head that people get tension headaches?
So it technically could happen any part of the head. A lot of times when people are experiencing jaw tension, they're getting temporal headaches. Because when you clench your jaw, you also clench the temporalis muscle, which is the muscle that's on the sides of your head. Those are what we call the muscles of mastication. They help us chew. And so you don't just clench one of them, you kind of clench all of them at the same time. And so unfortunately, there's bundles of nerves that go underneath that temporalis muscle, and they supply the sensation to the temples and to the face. And so people will when they're clenchers, they tend to get headaches kind of in that jaw, temporal, frontal area.
Yeah, that kind of the ram horns pattern or whatever, or horn.
Well, so that's different. The ram's horn's different because it usually originates from the back of the head, from the occipital muscles. So, and that pattern of tension can happen from the neck and shoulders and then affecting the occipitalis muscle in the back. And then it will sometimes wrap forward. Another pattern that we'll sometimes see is shoulder tension that actually radiates from the shoulder into the anterior neck muscles, the sternocleidomastoid, which then also will feed into the temporalis and into the jaw. So we see a number of different distributions of headache based on where those musculoskeletal patterns occur. And it can be different, from person to person. So again,
even like eye pain too.
Eye pain, yes. Yeah. So eye pain can come from the jaw. Eye pain can also refer from the occipital area. Mm-hmm. So and there can be like specific parts of the eye that are affected. So we look out for things like that too.
Yeah. And that, from like a physical therapy perspective, we're working on, we can, dry needle part of the face, mm-hmm. the upper trap, the jaw, the temporalis, the upper cervical spine, and then, strength conditioning, mm-hmm. working those inner neck muscles and things like that. Mm-hmm. But from your standpoint, what are some things, some of the lifestyle stuff that we've talked about?
Yeah. So I think, making sure that the musculoskeletal system is in good check is really important. And again, I think it just depends on what pattern of musculoskeletal, referral patterns you have. So it might be that maybe you need to work on your neck and shoulders, or maybe you need to work on your jaw, or maybe you need to work on the anterior angle of your neck, So it just kind of depends on the person and what's going on downstream, like we talked about before. Ergonomics is huge in our modern society. So we just are too attached to our devices. We're too sedentary. We're not up and about like we should be. And, when you spend 8 hours in front of a computer or spend, hours at a time looking at a tablet or a phone, it really takes its toll because you're in flexion for long periods of time.
Yeah, so sustained positions.
We need to find the time in our busy schedules to counterbalance that flexion. So we need to get up. We need to take breaks. We need to walk more. I think getting that 10,000 steps a day, actually, there's a lot to that because we're sort of forced to be out of flexion when we're up and walking. And, you can do other things too to improve your workstation, things like that too, so that it's not as impactful.
For sure. Yeah. I feel like, we do some ergonomic stuff too, but it's more of like, if you can have the perfect ergonomic setup, and if you're not moving, like yes. It doesn't necessarily, like you're saying, you have to move, and our bodies are meant for movement. And that's yes. also how we regulate our nervous systems.
Right.
Which can, if those are dysregulating, trigger headaches and all that stuff. So,
right.
And so now for kind of like the migraines and stuff, like what are some things that you do for treatment there?
For medication management, you mean? So we generally have a 3-armed approach for medication management. So there's prevention, there's acute medication, and then there's rescue medication. So for prevention, that's basically something that's in your system at all times to calm the brain down, to make it less likely to trigger, make you less likely to reach your threshold. It kind of raises the threshold higher, so it's harder to reach it. And I think of that particular arm as being where you can go more conservative versus more aggressive. So some of the most conservative but effective things that people can do are some supplements. A really, really big one is magnesium. It has the most evidence of all the supplements that have been studied in migraine. And most migraine patients have a relative deficiency. Their blood levels can be normal, but they still have a higher requirement for magnesium than the general population. And magnesium's a really great tool because it's a natural muscle relaxer. It helps with sleep. It helps with stress, anxiety. It hits a lot of those important, comorbidities, those triggering things for migraine. There are other supplements like riboflavin, coenzyme Q10, and then we'll look at things like vitamin D deficiency.
So huge.
It is. Vitamin D actually helps magnesium absorb. So if you're deficient in D, you can be deficient in magnesium as well.
I didn't know that.
Yeah.
Wow.
There's a really important connection there.
Okay.
And there are other supplements out there that have less evidence, but might be, interesting areas of research in the future. So I would say that's kind of more on the conservative side. And then we have a number of pharmaceuticals that will prescribe as well if for whatever reason the, supplements aren't enough and we need to add something else in there. And even there, some of the older school things that we used to use have some efficacy. We also have newer generation medications and injectables that we use for prevention. A lot of people think of Botox, for example, as being used only in the cosmetic world, but we actually use it in the medical world for a whole host of reasons. And one of them is for chronic migraine.
It can be really helpful for a lot of people.
Yeah, I mean, it helps to kind of relax muscle, which again, tension is an important component of migraine. It works on various pain chemicals. And then we also have some newer generation medications that work on a migraine-causing molecule called CGRP. So those are injectable monoclonal antibodies like Aimovig, Emgality, Ajovy, and Vyepti. And then there are also some what we call GPANT medications that are oral medications that also work on CGRP. So those are Nurtec and Qulipta.
What's CGRP again?
Calcitonin gene-related peptide.
What does that mean in English? Like, I think translate that to non-neurology people.
Right. Well, so I think the way to think about it, again, migraine being this brain syndrome. So the brain is very complicated, right? There's lots of chemicals occurring in the brain that are upregulating and downregulating. CGRP is one of the chemicals in the cascade of events that leads to migraine. So you trigger a migraine, CGRP levels go up. You treat with migraine medicine, CGRP levels go down. So it's just a very important part of that process. And it's kind of become a designer drug, so to speak, specifically for migraine, those started coming out in about 2018. And now there's multiple meds on the market for that. It's been very exciting for our field. Yeah.
That's huge.
Yeah.
So. Yeah, for anybody that's ever had a migraine, I mean, I never wish that pain on anybody. It is.
Yeah, pretty awful.
Yeah. And so for cluster headaches, then you said those tend to happen more in men?
Yes. Yeah. Okay. So those tend to follow a circadian pattern. So meaning they tend to happen kind of the same time of day every single day for a period of time. And they also happen seasonally. So they usually happen with like the changing of the seasons. So like in the fall and in the spring, those are kind of super common times. Some people get them more often than others. And basically you'll have that seasonal change and you'll have a daily headache for a few weeks to even a few months. And the problem with cluster headache is that they are the most debilitating form of headache. They are far, far worse than migraine, even though migraine's pretty bad. Migraine's considered a moderate to severe headache. Cluster headaches are uniformly severe when they occur. They're shorter in duration, about a max of about 20 minutes to an hour, whereas migraine is usually a minimum of 4 hours. But that, 20 minutes to an hour or a couple hours is very intense.
Yeah.
And then there are a number of medications that can be used to treat cluster headache. The options are less, but they do exist. In fact, CGRP is also involved in cluster headache. Melatonin is a natural treatment.
Really?
Yes.
Wow.
And then actually there's a lot of, for many years, there's an organization called Cluster Busters, where if you have cluster headache, there's a website that you can visit and they have a whole wealth of information about cluster headache. But for many years, Cluster Busters has touted the use of psilocybin for cluster headache.
I can't wait till we start legalizing more of that because it's just...
There's a lot of interesting research out there. In fact, Yale's doing a study right now on psilocybin and cluster.
Yeah.
Low-dose psilocybin.
For those people that don't know, it's the magic mushrooms.
That's right.
But no, I mean, there's stuff coming out on PTSD and all these things, and it can be life-changing for a lot of people. I'm just really excited for a lot of this stuff to come out because of its effects on the brain. I mean, it's fascinating.
Right.
And what do those headaches look like? Do they present in a certain way?
Yes. So they are unilateral.
So that means one side.
Yes, one side. Sorry.
No, it's okay. I'm just translating.
Yes, thank you. They are associated with what we call autonomic symptoms. So meaning, so it's a one-sided headache, and on the same side of the headache, you will have autonomic symptoms like tearing or redness of the eye, congestion just on the same side, runny nose just on the same side, flushing just on the same side. And then another component can be agitation. Whereas like the migraine patient tends to want to go lay down in a dark room and be quiet, the cluster patient generally gets really animated and agitated and paces and sometimes bangs their head against the wall even. So it can be really, really awful. Just that sort of behavioral component of it.
Do they have physical pain?
Yes. Severe physical pain.
Okay. And that's just kind of anywhere?
It's just on one side of the head. It's usually in the eye frontal temporal area.
But that mimics so much the tension headache.
Yes.
So how do you determine?
Again, I think the main distinguishing factor are the autonomic features.
Oh, I see. Okay.
So in tension type headache, you won't have those autonomic symptoms.
Okay. And so you said irritation in the eye,
redness, tearing,
maybe even
congestion, sweating, flushing.
Okay. Yeah, because autonomic for you guys is more of a change in your nervous system. So, if your heart rate increases and stuff and you get flushed more on one side, sweating on that side, anything that would basically occur if your heart rate increased, right? Or no?
Right. Potentially, yeah. Okay. I mean,
I'm trying to break down autonomic, but I don't know if that's the best way to describe it.
Meaning more like the involuntary nervous system. Because the nervous system, kind of has these things that it controls and that you don't have control over. Volitionally, right?
Yeah, your heart rate automatically.
Yeah.
Your heart automatically beats. You don't have to tell it to.
Right, correct.
But yeah. Is there, we talked a lot about lifestyle. Was there anything so we talked on 3 kind of major headaches or forms of headaches. And we talked a bit more on lifestyle prior. And so kind of jumping back to that. Is there anything that we did not chat about lifestyle-wise that...
Yeah, so I think, in migraine and tension type headache in particular, my top 3, maybe I'll say my top 4 lifestyle recommendations would be manage your sleep, make sure you're getting, adequate, restorative sleep every night, manage your stress, and manage your musculoskeletal system. And then, so those were kind of my top 3 for years and years. And then probably in the past couple of years, I've added a 4th, which is alcohol avoidance. Because alcohol, unfortunately, causes a lot of problems. It's inflammatory. It messes with your sleep. It increases your risk of cancer. There's lots of negatives to alcohol. And so more and more, I'm telling my patients to avoid it.
I think there's actually a big shift, especially in the younger generations, the Gen Zers.
Yes.
To avoid alcohol.
Right.
I mean, I don't drink. I mean, I might have one drink every few months or something. I just don't respond well to it.
Right. Same.
But it's fascinating to kind of see this shift, at least in different generations, right?
Yeah, the newer recommendation is if you've never had any alcohol, don't start.
Yeah.
Because it's just better for your body to not be exposed to those cancer-causing.
Well, I think we've just normalized it so much that the fact to take it out just seems so insane to people. But, it's one of those things where I'll go out and I'm just I think people don't know what to do because they're like,
yeah.
Are you not drinking? I'm like, no, I don't really drink.
Right.
And it's just like, wait, what? Why?
I know.
And I'm like, no, like this, I'm not judging you if you want to have some drinks, but I get inflammatory. I get tired. I get puffy.
Right.
I just like, and then.
I think it's hard. It's been a part of our society for millennia. I mean, how do we get away from, something that's so ingrained in our social fiber,
Especially around the holidays when you're with family.
Oh, yeah. All right.
Like, maybe that's what you have, but no, I think then people can start looking at it and realizing it. And I didn't even realize this too. But there's more and more like, there's a couple places in Austin that are like sober bars, just fun cocktails and just going out. And I think that sometimes people think, oh my gosh, well, if alcohol's out, well, I have a social life and you can get there.
Yeah.
I mean, I've gotten to the point where people are like, are you drunk? I'm like, no, this is my personality. I'm just weird, I don't need alcohol to make me weird.
Exactly.
Cool. Is there anything else that you wanted to touch on before?
I can't think of anything right now.
Oh my gosh. I just love all of this information.
Okay.
I think it's great. So, well, thank you so much for coming.
Thanks
we
for
will
having me.
tag her information below. And yeah, I'm really excited to share this with people and give them information that they didn't necessarily have before.
Awesome.
Thanks for coming.
Thank you.